over it again?
I'd be glad to. Renee here, do you guys, you know what atrial fibrillation is?
Well,
Have
yeah,
heard
if
of
you
it?
could, we were
Okay.
kind of thinking
You know when
exactly.
your heart beats, it goes lub-dub, right? You ever hear people talk about lub-dub? The top half of the heart squeezes blood to the bottom half of the heart, and then the bottom half squeezes that blood out to the body. One half of the heart pushes it to your lungs and back to your heart, and the other half pushes it to your whole body, and then it comes back to the heart and goes around again. And that should be coordinated. So the top half of the heart should squeeze, and then shortly after that, pushes blood down, and then the bottom half squeezes and pushes it out of the heart where it needs to go. In your situation, the top half of the heart isn't squeezing coordinated. It's kind of doing this. So the bottom half squeezes periodically, but because it doesn't get a coordinated, we call a bolus or a chunk of blood in there for each beat, it can't push blood through as effectively as it should. And as a consequence, things start backing up. And it's almost like someone who has congestive heart failure, but yours is because of an underlying thing that when we correct it, that should clear up. So it's not like someone whose heart is damaged. And it's not usually because of heart damage, like a heart attack or something like that. It can be associated with that or a valve problem, but usually it's just bad luck, is the way I'd say it. For whatever reason, the electrical system of the heart gets confused. So some people can have this and have no symptoms at all because their heart never goes really fast. In some people, and this is why you got more symptomatic, is it's probably been going on for a little while but didn't get going really fast. But sometimes the bottom half of the heart, without that steady impulse, starts beating too quickly and it starts going faster and faster. And the faster it beats, the less it fills up because it doesn't relax completely. And so it's hard to get blood through the body like it needs to. And that backup causes some fluid in your lungs and some swelling in your legs and makes you short of breath and things like that. So people that have it really bad and their heart rate gets some 140s, 150s, it can provoke heart damage sometimes because the heart's working so hard. We don't believe that's happened with you, at least not yet. I think you just, heart rate was going too quick and you had symptoms and it just kind of kept getting worse. So there's two goals. One is to get your heart rate under control, and the other is to prevent you from having a stroke. And the reason why your risk for stroke is higher is because that top half of the heart flopping around, the blood can pool and clot. Just like if you have a cut and you let the blood sit on your skin, it clots. If the blood sits in the heart, even though the heart's moving all the time, it gets little eddies and that can clot. And then if it gets a little beat and it flips down and up that clot goes and into your brain or somewhere. So the first thing we do is get your rate down under control, and then we need to talk about thinning your blood for a period of time. And for some people, that's long term. For some people, their heart flips into a regular rhythm, and several months later, we can take them off the blood thinners. I'm going to have a cardiologist see you tomorrow, just to make sure structurally there's no concerns. We're going to get an ultrasound of your heart, make sure that the valves are all okay. And he'll probably talk some about blood thinning stuff too. But you've heard of Coumadin before. That's an option. It's the cheapest out there, pill-wise. Then you got to get blood tests all the time, and it can be real finicky to control those levels. There's newer ones out that you just take once or twice a day, and you don't have to do any blood work, and they're much easier to deal with. They both work just as well. They both have the same risks of bleeding if you hit your head. You can get bleeding in your brain. All those things that can happen when your blood is thin. But it's just more convenient. The downside is it can be more expensive because there's no generics. Most insurances cover, there's 3 or 4 of them out now, but that would be an option too. And we don't have to make the decision before you leave the hospital necessarily. We can get you some samples and keep you in it for a while until we figure out what your insurance covers and you can make a decision. So that doesn't need to be a stressful decision, but we need to make sure your blood is thin so we don't run the risk of a stroke. That's the biggest complication that could cause harm to you when you have AFib. The heart rate we control with medicine, and you're getting some in the IV right now, and it's working really well. You've been down under 100 pretty good. So we're going to transition you to just oral medication that'll help do that. And that may be all you need. Sometimes that's not enough, and we need to add some on, and that's why I like to have the cardiologists available too to manage some of those fancier medicines if we need them. But usually that's not a big deal. A lot of people say, well, why don't you fix the heart rhythm so it beats regular again? And in some people that's appropriate. In other people, the risk of doing that is greater, causing a problem than just letting the heart beat irregular if you can keep the rate under control. And as you get older, that risk tends to be a little higher because you like have to shock the heart. There's different ways they do that. Sometimes if we're lucky, it'll fix itself. So we get you on the medicine, sometimes in the first 24 hours, all of a sudden, whoa, it's nice and regular again. And whether it stays regular or not, it's hard to predict. It's just, you just have to pray about that one. But our goal isn't necessarily to get you back to a regular rhythm, it's to keep it from being too fast. Does that make sense? Okay. So overnight tonight, we're going to just keep an eye on your heart rate. We'll probably wean you off the IV and give you a pill form of it and see how you're holed up during the night. See what the cardiologist says tomorrow. I don't think he's going to have any, fancy thing to tell you that we haven't already discussed. But we'll kind of have them keep an eye on things too, because you got a lot of other medical things to juggle, and I think it'd be good to have them involved. You have any questions on that part of it?
No, I guess not.
It's a lot of
I was
information.
gonna land here and have to be here a while though.
Well, the only reason you're in ICU is because you got the medicine in the IV dripping. If we didn't need that, we'd have you on the regular floor. It's not usually that critical of a thing. So, and I don't think there's damage to her heart, but we'll see with the ultrasound tomorrow. And we'll check some blood work through the night as well to make sure there isn't any heart enzymes that elevate, that would suggest that your heart had any damage. But usually, again, that isn't a big issue with this. So we'll let you eat something for breakfast, and things like that. We're not gonna make a lot of changes with your other medicines even. We just need to kind of get this under good control. I mean, your oxygen's doing great just on room air. Your heart rate's doing fine. If we had you get up and walk around, it'd probably go up though. So I mean, we still got a little work to do, but it's doing much better. So I'll come back tomorrow. You'll probably have questions. I'll come see you probably over lunch though. And whether you go home or not tomorrow kind of depends on if we can get everything done and if we can control your heart rate. You may be able to go by tomorrow. Sometimes it takes a day or two to get the extra. We'll give a little medicine to get some fluid off of you too, so you don't feel so overloaded, and that'll help your breathing. But we don't want to do a lot of that and make your potassium get too low either. But that'll help a little bit as well, kind of unload your heart so it's not working as hard.
Check that out.
Your hemoglobin level is great, 12 point something. So fortunately your anemia wasn't an issue. If we had caught you when your blood was getting low, this would have been a lot more stressful for your body. So that's good news. When you were really called and you were winded, I was thinking, she's probably really anemic again. But I was glad to see that was normal.
That's what I thought.
Yeah. So. Any questions on that? Kind of
So
make sense?
that causes the fluid?
It doesn't necessarily cause the fluid, it's just that it makes it hard for the fluid to keep moving through her body the way it should,
Okay,
and it kind of
okay.
backs up.
Okay.
So it really isn't so much that she's overloaded necessarily, but
Uh-huh.
giving her a little bit of fluid of Lasix sometimes
Yeah.
can help give her some relief with her breathing.
Okay.
There's a blood test called a BNP we did, which doesn't matter what it stands for, but it's a measure of how much strain the heart muscle is under. And it should be under 400, and hers was like 8,000. Now that doesn't mean that her heart's 80 times damaged at all.
Yeah.
It just is an indicator of that her heart's been straining because this has been going on for a little while. And so we want to try to keep her heart from working as much as we can, and sometimes taking some fluid off will help with that.
Okay.
So we don't want to do too much, so otherwise the heart tries to compensate by speeding up, and we chase our tails. So we're not going to do a lot of that. So
Okay.
okay. And with regards to blood thinning stuff, we'll probably just give you shots tonight and in the morning to do that. And then after cardiology talks to you, if they have a preference, we'll go with that. If not, we'll talk about which one you want to try first. And usually what I'll do is have you pick up samples on your way out. Most people want to go with the newer stuff because it's easier. If you decide you want to do Coumadin, we'll start that. But usually what we'll do is give people samples of one of the new ones and then have them go to the pharmacy and see how well it's covered, and if it's not, see which one's better, and we'll keep you in samples until we get that sorted out.
So what did she initially start with? It's confusing to me.
That made her not feel well?
Yeah.
Chances are her heart was beating irregularly for a little while.
Oh, so it started with the heart.
Probably so, yeah.
Okay.
And it could have even been, it's been a little while since she's been in to see me, but sometimes you listen to the heart, and like if you look at the peaks on our monitor right now, you see how they're pretty even? Like there's a funky beat once in a while, but some people come in and they're really close together, then there's a pause, and it's very irregular. And so some people, particularly as they get older, you listen and they sound perfectly regular when you listen, and unless you have an EKG on it, you would never know they were in it. But like other EKGs we've had on her in the past never showed it. So I don't, who knows? It could have been 3 months ago. It could have been
Yeah.
3 weeks ago that she started doing it. So, and sometimes it's related to thyroid and stuff. I'm sure they probably got that in your blood work. I'm going to review that when we're done, but we probably won't be that lucky. Sometimes you can fix that and then it goes away too. But
Yeah, okay.
the medicine we use to control your heart rate brings blood pressure down some. So we want to be a little careful. We can't just dump it all in her and then she gets
Yeah.
all lightheaded too. So you
Right.
got to kind of balance those as well. So there's a little bit of an art to it. But yeah, chances are it's been irregular for a little while, and just as her body further and further kind of had trouble keeping up, she got more and more symptomatic, and it may be because of kind of the overload or the backing up of all that her heart really started taking off, trying to just beat fast enough to keep up, and that's when she really started feeling miserable. So.
Okay.
And I couldn't walk hardly from here to the wall.
Without getting winded, yeah. And actually, when you come in and this is going on, it's actually a good thing because it's like, oh, well, we know what it is, we can fix it, we can treat it, we can take care of that. It's a lot better than like if someone comes in and they have heart failure because their heart's dilated or they've had a heart attack and they didn't have symptoms or whatever. So, I mean, there's a little bit of a silver lining. This is something that we can correct a little more easily for most people. So that's good.
I hope so.
Yeah. You've never seen any cardiologists before? Yeah, I didn't think so either. I'm not sure who, there's always one here each day, but I'm not sure if he's a Parkview guy or a Lutheran guy. I think they alternate, but we'll take whoever's here tomorrow. They all seem to do a good
Does
job.
Dr. Dustman come up here?
I don't think so. I've heard his name, but I don't think he comes up here. Now,
She prefers Lutheran if there's
Oh,
happens
okay.
to be anything serious, but I don't
sure,
think we have to.
and that's okay. They'll switch back and forth if need be.
Oh, okay.
So, I mean, if this is a Parkview guy and they decide to do some testing and you guys say, well, we kind of would rather do it at Lutheran, I mean, I'm sure they'll work with you on that. But,
Is that Dr. Dean Shiley today?
Oh, I don't know.
Schreffler.
Yeah.
Schreffler?
Yeah, the emergency room.
The emergency room doctor?
Yeah,
Yeah, Dr. Schreffler.
we were impressed with him.
Yeah, he's a great guy. He's actually a family doctor. He trained in here in Fort Wayne. He got out about the time I did, but he went right into the emergency room and he never